My name is Negar Ahmadi. I'm a fourth-year general surgery resident from Ottawa, Canada, and I'll be talking about impact of surgical approach on perioperative and long-term outcomes following esophagectomy. Sorry, it skipped the conflict of interest slide, but no conflicts of interest. There's been studies that have actually compared minimally invasive esophagectomy to open esophagectomy, and they've mostly consistently shown decreased intraoperative blood loss, increased OR time, decreased length of stay, and decreased postoperative adverse events. But when you look at the literature, there's only a few studies that have actually followed these patients in the long term and looked at oncological outcomes. So the objectives of this study was to look at perioperative and postoperative outcomes in these patients and to assess oncological outcomes. Of all esophagectomies done at our institution from 2001 to 2015 for malignancy, and for the purpose of this study, we defined transthoracic and minimally invasive esophagectomy, or Ivor-Lewis esophagectomy, as combining laparoscopy and VATS. And transthoracic open esophagectomy was a laparotomy and thoracotomy, or a hybrid of one part of the operation being done minimally invasive and the other part open. So in terms of the statistical analysis, routine stat analysis, the only thing to highlight was the propensity score matching that was done in this study to assess survival among minimally invasive versus open esophagectomies to account for some of the confounders. And this is the distribution of the surgical approaches done at our institution. So a total of 309 attempted esophagectomies, and of those, 18 of them were aborted, and they were all because of disease progression. And then of those, 25% were MIE, 47% were open, those are both Ivor-Lewis, transthoracic, and 11% transhiatal, and 17% 3-incision. And for the purpose of this study, we're essentially comparing these two groups. Patient characteristics, comparing the two groups, you can see that they're both male predominant in the two groups. Median age was similar in between the two groups. So was the BMI as well as the ASA distribution. The minimally invasive group, there was a significantly larger proportion of patients who underwent neoadjuvant treatment, which is consistent with some of the changes that's happened with treatment of esophageal cancer in the last decade. So the majority adenocarcinoma, lower third or GE junction, again, is the majority of the tumors. And then the final stage, which is the final pathological staging, you can see that there was a significant difference in the distribution of final stage, with the open esophagectomy group having larger percentage of higher stage and fewer stage 1. Number of lymph nodes retrieved was interestingly different between the two groups, with the minimally invasive esophagectomy again having significantly more number of lymph nodes retrieved, and that's the median, compared to the open, and similar R0 resection. Estimated blood loss was significantly less. So looking at post-operative adverse events, so the classification system that we used is the thoracic M&M, which was actually developed at our institution. It's similar to the Dindoclavian classification, but it's been validated specifically in thoracic patients. So you can see that there was a difference in the distribution of adverse events, with the open esophagectomy patients having more events that resulted in ICU admission and single or multi-organ failure. No difference in mortality, and the length of stay, as expected, was significantly longer for the open esophagectomy. So then we looked at survival, comparing the two groups. And you can see the blue line, which is the open esophagectomy, is much longer because of longer follow-up term. But essentially, they were somewhat similar between the two groups. And then we looked at disease-free survival, and you can see it appears that the minimally invasive group has an advantage in disease-free survival. But you might say there's been a lot of changes with perioperative care, postoperative care, and neoadjuvant treatment, which might be affecting these results. which is why we did propensity score matching to look at survival. So we identified 69 matched pairs, and these are the variables that we use to find these matched pairs. And there was no difference in overall survival and disease-free survival. And these are the two, the same curves, but for the matched pairs. And again, you can see the graph that's on the right side is now essentially the same in both groups. If you remember earlier, I showed in the table the minimally invasive esophagectomy having a greater extent of lymphadenectomy. So again, you might say, is that because of better pathological examination of the specimens by our pathologists? So we did, again, a matched pair. We identified 73 pairs based on these factors. And there actually was a statistically significant difference with the number of lymph nodes being, on average, about 14 more lymph nodes retrieved with minimally invasive. So just to go over some conclusion points, patients undergoing MIE are very similar in their baseline characteristics. Patients undergoing open esophagectomy are more likely to have advanced disease, and a lot of that could be attributed to MIEs are done more recently, and there's been a significant change in the practice of treatment of esophageal cancer with neoadjuvant treatment. MIE is associated with significantly less blood loss. You might notice our OR times are a little bit longer than some of the previously reported literature. Part of that is because this includes the anesthesia time as well. Patients undergoing MIE are less likely to develop postoperative events that would require an ICU admission, and there's, after our propensity score matching, there's similar survival and disease-free survival. And the interesting, I guess, the conclusion from our study was that MIE yields significantly more number of lymph nodes. Is that better visualization with the VATS and the laparoscopy? This is actually something that's been demonstrated in a number of other studies, and it remains significant even after the propensity score matching. There's still an ongoing debate as to if there is a survival advantage of the greater lymphadenectomy. And that's it. Thank you.
I have a quick question for you. In the propensity score analysis, you use one of your covariates was the number of lymph nodes retrieved. This is an outcome. So you can't use one of your covariates as one of your outcome.
We only used it in the first propensity score matching when we did the survival and disease-free survival. Well, we actually did not use it in the second propensity score matching model.
So you use it twice?
Used it only once.
No, I'm saying you used propensity score analysis twice.
Yes,
okay.
That's right.
Hi, Brandon Schleger from Seattle. How many surgeons in your group do esophagectomy and are included in this study? Did they adopt minimally invasive esophagectomy on the same timeline and with the same proportion? And where I'm going with this is that there's very likely that surgeon-specific related factors may be attributable to the differences you're seeing. Did you control for that, and how?
Yeah, there's 6 surgeons that do esophagectomies, and 5 of them do minimally invasive esophagectomy. There were differences in terms of the timeline that they adopted the minimally invasive approach. Fortunately, there wasn't, the only way would be to exclude the surgeon who primarily does open esophagectomies, but this analysis didn't account for it.
Thank you very much. I think we'll have to stop. I'm sorry, we are running behind by about 7 or 8 minutes. Thank you very much for your presentation.